From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, my name is Dr. David Simel, and I am an associate editor for JAMA. In this JAMA podcast, we will be discussing the standards of care for the health of transgender and gender-diverse people that were released as version 8 by the World Professional Association for Transgender Health and released September 2022 in the International Journal of Transgender Health. We are pleased to be joined by Dr. Andrew Davis, who is a general internist and professor of medicine at the University of Chicago. And we are also joined by Dr. Tonya Petit, who is an associate professor in the Department of Social Medicine at the University of North Carolina, where she is a clinical preceptor for their gender-affirming care clinic. Dr. Petit is a physician assistant who has a doctorate degree in international health from Johns Hopkins University. Dr. Davis and Petit are the authors of the clinical guidelines synopsis that appears in JAMA in the June 6, 2023 issue. Thank you both very much for joining us today.
It's a pleasure to be here.
I'm happy to join you.
Dr. Petit, the guideline that you summarized has a glossary that defines many terms, including those in the title of your synopsis. Can you describe the umbrella terms transgender and gender diverse so that our listeners understand who the guidelines apply to?
Yes, thank you so much for that question. I think it's important that we all understand the terminology that we're using. Transgender and gender diverse are terms that are used to describe people whose gender identities differ from the social and cultural expectations that are usually attributed to the sex they were assigned at birth. It basically means that anyone whose expression of their gender or identity for their gender is different than what's expected from what's on their original birth certificate would fall under this broad umbrella.
Okay, Dr. Davis, you were tasked with summarizing a 200-page guideline to highlight the recommendations that could be most important for generalist clinicians. And in doing that, you started off with recommendations for basic primary care, where you noted that it included gender-affirming primary care. Can you talk a little bit about the components of gender-affirming primary care?
I'd be glad to. I'd like to give a little background of how I found myself learning more and having this kind of practice. I've been a primary care physician for over 30 years. I'm in an adult group practice at the University of Chicago, and I also see students and grad students there. And I began to see transgender patients about 8 years ago, initially asking for continuation of hormone therapy. And I realized I was already giving testosterone in shots or patches for patients with hypogonadism, and I was already using estrogen pills or patches for patients going through troublesome hot flashes near menopause. And then I also saw that I was prescribing spironolactone for patients with hypertension and heart failure. I began to appreciate that this was not simply a whim. This is a marked and sustained difference, as Dr. Petit was saying, from the natal birth. To give an example, I was seeing someone who was transitioning from female to male who had terrible asthma and was wearing this horribly confining chest binder that was making her asthma worse, had been doing so for 3 years. This was somebody that really had a medical issue for me to pay attention to. It was thinking about mental health issues. It was thinking about tobacco, alcohol, and substance abuse. It was thinking about diet and exercise, screening for sexually transmitted disease. And there were a few other things, like being alert for blood clots, which I already have been doing for patients on birth control pills. And these are things that I realized I already did. As I saw more transgender patients and addressed their needs, I became quite comfortable with this care.
Okay, Dr. Petit, transgender and gender-diverse adults may at some point desire the gender-affirming medical and/or surgical treatment that Dr. Davis alluded to. When should gender-affirming medical and/or surgical treatments be offered, and how are the patients assessed for that?
Thank you. Those were really great questions. And the guidelines are very clear that any qualified health professional is able to do these assessments. There is a previous understanding or expectation that a mental health professional was required to do these. But in fact, anyone who is a qualified health professional with the education and training necessary can do these assessments. It doesn't require a specific role. There are four main areas that should be assessed for anyone who is seeking gender-affirming medical or surgical care. The most important being the capacity for informed consent, which is what we would expect from any patient that would be providing care for. The second is something that Dr. Davis alluded to identify whether there is a sustained and marked difference between the sex that someone was assigned on their original birth certificate and their current gender. And that can be done through history taking. And ensuring that any other physical or mental health condition that that person may have that could be affected by starting hormone therapy or by surgical interventions have been adequately assessed and addressed and are well controlled as much as possible before initiating therapy. And I think what's highlighted in these set of guidelines, more so than prior guidelines, is making sure that there's a discussion between the clinician and the patient about any reproductive implications of the therapy that they're going to be undertaking and discussing options for fertility preservation if that's something that's desired. I think it's also important that psychotherapy is not a requirement before gender-affirming medical or surgical therapy. There are obviously some patients who might find it helpful to have that kind of support as they're making life changes, but it is not a requirement prior to initiation of gender-affirming medical and surgical therapy. I think it's also really important to note that the guidelines note that therapy designed to change someone's gender identity or expression should not be offered. There's a growing body of evidence that such interventions actually cause psychological harms. So the assessment is actually pretty straightforward. Anyone with the experience and training can do it. Informed consent, ensuring that there's sustained differences between sex assigned at birth and current gender, managing other health conditions, and discussing reproductive options. And those are all specific to care for adults.
As a primary care physician, the new 2022 standards of care are a marked advance in my mind from the 2012 guidelines. There are 16 chapters with useful information, including a chapter specific to primary care. If you have questions about how to monitor hormones, they say if you're giving testosterone to someone, you shoot for a level between 400 and 700 and you check it every 3 months. You would check a hemoglobin a couple times a year. If you've got someone who is transitioning from male to female, you shoot for a dial of 100 to 200 and you work to get the total testosterone less than 50. If you're using spironolactone to help with hirsutism, you simply keep an eye on your potassium and your electrolytes. So these are things that we do all the time in primary care, and they're straightforward and come as second nature after you've worked with a number of cases.
The Standards of Care version 8 does talk about the role of primary care clinicians and notes that primary care clinicians should be able to manage the comprehensive health of transgender people, either directly or by appropriate referral. They specifically say about hormone therapy that whether or not a patient receives medically necessary gender-affirming hormone therapy from a specialist or a primary care provider is going to depend on the availability of knowledgeable providers and country-level factors, such as healthcare regulations and health services funding. Can you talk a little bit about that?
I would say one of the key things in primary care is, do you have a network of people who have interest in transgender care? So here at the University of Chicago, we have a trans care group that we meet on a Zoom call once a month, and we have endocrinologists, we have pediatricians, we have surgeons, we have voice therapists. And there's actually an excellent article in Academic Medicine in May of this year, in 2023, from Johns Hopkins, where they talk about building a center of excellence for transgender care. At a broader level, it takes some work to understand who you can refer to, but I think working together in a collaborative way helps you refer to the right person at the right time and gives patients much more confidence when you understand the different dimensions of what people need.
I would add that what you point out really importantly is that the guidelines are written for the entire world. They were written by the World Professional Association for Transgender Health, and the settings in which people will be providing and receiving gender-affirming care will vary greatly depending on the country and the health system in which they operate. For the vast majority of patients that I've seen over the last 20, 25 years of my practice, they are fairly healthy people with few comorbidities, and managing their gender-affirming care is really one of the simplest things that I do in the course of my day. I think for more complicated situations where people may have other comorbid conditions that might complicate management of their gender-affirming care, then as Dr. Davis mentioned, it would be important to have access to a referral network of people who not only are knowledgeable about gender affirming care, but I would say also to make sure that the patient is treated with dignity and respect, no matter whom they see.
And I do adult care, so all of my patients are 18 and older. I think the evidence base is thinner for transgender individuals under the age, say, of 16 or 18. And the guidelines are very explicit that in that situation, you're usually talking about a multidisciplinary team with lots of that expertise built in, a quite rigorous assessment. You are talking about weighing the pros and cons of things like pubertal blockers, hormone therapy at earlier ages, which are areas where we are filling in our research knowledge.
Dr. Poteet, could you address a little more how the assessment of children and adolescents might differ from the assessment of adults for gender-affirming care?
When assessing someone who's an adolescent or even a child, consideration should be given to what their actual age in years is, and also their developmental stage, both psychologically and physically. What their neurocognitive function is, their ability to understand the kinds of decisions that are being made and the implications of those decisions, the language skills, all of those things need to be taken into consideration. And as Dr. Davis pointed out, a multidisciplinary approach should be taken with the caveat that, again, these guidelines are for the world. And there are places in the world where the benefit of a gender center with specialists from a variety of disciplines aren't available, but access to that information might be available in our very connected world. And I think people can think broadly about how to access that multidisciplinary information. Two really important points to make is one, that the guidelines do recommend that parents or guardians should be involved in almost all situations. Those are the folks who are really trying to make the best decisions for their family with their kids. And I think the second is that they make a distinction between care for children and care for adolescents. Gender affirming care for children almost never involves a medical or surgical intervention. It is almost universally a social transition. So changes in things like name, hairstyles, clothes, those kinds of changes are the kinds of gender affirming interventions for children. For adolescents who've reached Tanner stage 2, those are the folks for whom things like puberty blockers are really being considered. And I think that distinction is really important.
I think another thing is it takes a comprehensive multidisciplinary effort to really sort out who generally has gender dysphoria, that marked incongruence, which is sustained and persistent. And we've tended to go to these specialized societies using a rigorous intake process, such as the Dutch have done for a number of decades. And with that, it's not simply a whim. It's a very thoughtful process involving the guardians or the parents and the child, often over many years, before you make a leap into things like pubertal blockers.
That actually provides a nice entry to a question that we haven't addressed yet, which is the mental health needs and challenges that these patients face. Could you address that?
I'm a researcher in much of my life, and a lot of the research that we look at is related to mental health among trans and gender diverse patients. As long as there's been data on gender identity, we have a lot of information about the high rates of depression, suicide, and anxiety among transgender people, often related to stigma and discrimination that they experience in society. And I would say one concern that I have is that a rigorous evaluation does not need to be a prolonged evaluation. We do have evidence, and we talk about this in the article, that delaying unnecessarily access to gender affirming care has been associated with worse mental health outcomes. So we don't want to unnecessarily delay access to life-saving care for folks who need it. But we do want to make sure that the care that we provide is high quality, appropriate, and thorough.
Okay, well, let's talk a little bit more about evidence. Dr. Davis, all guidelines depend on a systematic and thorough review of the evidence that is also paired with experts' opinions when there are gaps in the evidence base. Can you tell us about the strength of the current evidence base in terms of where it is really strong or where there are gaps that need to be addressed?
Yes, I'm glad to. What we look at is the weight of evidence, systematic reviews where possible. A systematic review from the Johns Hopkins Evidence-Based Center that accompanied this guideline found that gender-affirming hormonal therapy was associated with improved quality of life, decreased depression, and decreased anxiety. There's less certainty about its effect on suicidality. Multiple papers show a consistent increase in suicide risk in transgender individuals, with perhaps 15 to 40% reporting a serious suicide attempt. The methodology is somewhat challenging, including whether a study is talking about suicidal ideation, a suicide attempt, or a completed suicide, but the overall trends are quite clear. The review covered papers up until June of 2020, and there have been a number of strong papers published since that time. I think in adult care, there's an emerging consensus that gender-affirming medical and surgical therapy is beneficial. In our short paper for JAMA, we talk about some of the data supporting gender-affirming surgical therapy as well. For pubertal blockers, which delay puberty, research attention is on bone loss and the future risk of osteoporosis, particularly in folks that are transitioning between male to female. And we're also getting more research on the long-term effects on sexual function. But again, the outcomes are generally positive, even as we seek to gain more data.
Well, before we wrap up, are there any further points that either of you would like to communicate to our listeners about the health care of transgender or gender diverse people?
I'd just like to point out that the most recent national survey that was conducted by the U.S. Census Bureau indicated that there's more than 2 million Americans that identify under this transgender and gender diverse umbrella. So it's really highly likely that a primary care clinician will encounter transgender and gender diverse patients in their practice. So it's important that everybody have the basic education about gender identity, even if you're not going to be providing gender affirming medical or surgical care, that you be able to treat all of the patients with the appropriate dignity and respect. For example, doing something as simple as asking the patient what name they go by or what pronouns they use so that you refer to them in a respectful manner can go a long way towards creating a welcoming environment and ensuring that all of our patients get the care that they need and deserve.
And picking up on Dr. Poteet's point, in our article, we have a link to offices which are looking to make their offices more gender affirming. It's a simple PDF that's actually linked in our article to give you tips like that. For practitioners who are interested in learning more fine points, I would refer them to the full guideline. And there are also terrific resources such as the Fenway Institute in Boston, as well as the University of California at San Francisco transgender guidelines put together by Maddie Deutsch and her colleagues. This is an underserved population, perhaps 1% to 2% of the U.S. population. We've said gender diverse and transgender. We're seeing people that are not making a complete transition necessarily from one gender to another, but we're seeing people that are non-binary or perhaps doing partial transitions. We are seeing different variations rather than one gender and then an absolute switch to another. The other thing that's interesting to me in the literature is that psychosocial support is absolutely huge, and in some ways maybe as powerful as some of the hormonal and surgical therapies. So I think you treat people with respect and dignity and are aware of who's got the skills in your practice or area. That makes a huge difference in addressing the stigma and the rejection that many patients fear. They come into the doctor's office and their fear is that they'll have someone who will judge them, someone who won't give basic blood pressure control, cholesterol control, screening for health practices. And doing that makes an enormous difference in the outcomes. I would also say, just personally, in my practice, I see 1 to 2 transgender folks a week. And the smile on people's faces when they get good care after coming in initially fearful is one of the real highlights of my practice week.
Dr. Davis and Dr. Poteet, thank you very much for this discussion and your insightful comments about this important aspect of healthcare. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, visit us online at jamanetworkaudio, all one word, .com. Thanks for listening.